So my project was a quality improvement project regarding assessment and documentation of wounds. I've been following wound care for the last several months, seeing how their process is, how they work with the nurses and with the interdisciplinary team to provide wound care to patients. So my problem statement is, what are the best strategies for early assessment and documentation of wounds? The background has been that recently there's been some root cause analysis that have led to some serious pressure injuries that have impacted patients where there was no documentation to back up that it was not hospital acquired. So as of 2008, the Centers for Medicare Services no longer reimburses hospitals for any stage 3 or stage 4 pressure injuries that are acquired during a hospital stay. So that is a significant cost that a hospital basically just has to pay for because they won't get reimbursed for it. However, if there had been adequate documentation, then we could have proven that those wounds were not hospital acquired. So that is where you guys come in. Part of the background is why is it so important? We're going back to the cost. Estimates are hard to pinpoint, but there is approximately $11.6 billion is spent in the U.S. annually for the treatment of wound care and pressure injuries. And I say pressure injuries, they recently changed the terminology. You're used to hearing pressure ulcer. Pressure injury is more of a term that, because they're not always ulcers. Ulcer implies it's some sort of induration, it's something gross, it's not always that way. Individually, one pressure injury can cost anywhere from $500 to $150,000 for one patient, and that's just in the hospital. We're not talking about the care that they may need in a rehab facility or home care. It's also very highly litigated. I don't know if you've ever come across a patient or family member who has said, well, you know, they got this sore on their butt while they were here, and kind of making it sound like it was our fault. They're subject of lawsuits. At least 17,000 lawsuits a year are brought to the courts due to what we feel our hospital acquired. So obviously the why is because we want safe and effective care for the patients. That's most important. It also improves outcomes. So pressure injuries increase the length of stay, they increase mortality and morbidity, and they reduce the quality of life. It utilizes our wound and ostomy nurses. So we are very fortunate that within Novant Health, we have a dedicated wound and ostomy team that serves the inpatient population. Not all hospital systems have that, especially the smaller hospitals. So we have full-time nursing staff that just, all they do is wound and ostomy care. And all they do is see the patients, put in orders, they do reassessments, they work with the nurses and the doctors to find out what is the best implementation we need to get the wound healed. And it also helps for coding and reimbursement. If something is documented incorrectly, then we have to, it's a long process to go back and get that changed, because if something is coded a pressure injury and it maybe is something due to incontinence dermatitis or it's due to vascular insufficiency, it's hard to go back and change that. What are the challenges? So time. So I read a study that said that nurses spend about 50% of their shift charting. I would say that it might be a little more. Like if you have 6 patients and you've got a chart for 6 patients for 12 hours, you might actually spend a little bit more, depending on how complex they are. Working in critical care, we have to do more frequent reassessments. We have to do more frequent vital signs. A lot of times we don't have a CNA working with us, so we're spending at least 50, if not maybe 60% of our time charting. So charting on a wound may be not like your top priority list, as opposed to charting your medications and charting your assessments and charting your vital signs. Documentation knowledge. So a lot of nurses don't know how to document wounds. You look at this and you're like, I don't know what it is. It's red and it stinks, or I don't know what to classify this as, and that's okay, because that's why we have the wound care team to do it for us. All we want to know is there's some sort of skin impairment on this patient. So I would highly recommend that, and I'm going to get to my implementation, and I'll show you how that you can learn more about how to document wounds, because I think a lot of us, we come from different hospitals, there's different policies and procedures, and we just don't know how to document it. All you need to do is be objective. Document what you see, where is it? That's about all you need to know. You don't need to know how it got there, why it got there, what you need to do for it. Let the wound care experts do that. And finally, you don't know how to consult the wound ostomy nurse. Some of us may not even know that they existed, especially we have some travelers, we have new nurse residents, we have some new graduates and some that come from other systems that may not know what the policies and procedures are. So we get to our implementation, and these were my top strategies to kind of get the ball rolling for how we can improve the assessment and documentation component. The first thing is a head-to-toe skin assessment documented on admission and validated by 2 nurses. So I learned quickly when doing this head-to-toe skin assessment with the wound care team, it takes a couple minutes. It really doesn't take long at all. Just say, hey, we're here, and you just explain to the patient, hey, we're here to look at your skin. Most of them don't have any problem with it. You're listening to their heart, their lungs, you're doing their neuro assessment. It's just one more step. And the reason for having 2 nurses is that you're going to have a second set of eyes. How many of you have gone to your coworker and said, hey, can you come look at this? I don't know what this is. Can you come listen to this patient? They just don't sound right to me. It's the same concept. They may see something that you might miss and vice versa. And that way you've had documented that 2 nurses have looked at it. You can also utilize your AET nurse to be your second set of eyes. Sometimes you might have, your manager or a charge nurse if that's available, or you just get your coworker buddy and you can tag team on your admissions, and it really doesn't take very long. The second one is accurate documentations of wounds, and I talked a little bit about terminology. Part of the Novant Health, I printed out some policies and procedures. Part of the Novant Health policy is that only providers and the wound ostomy nurses are actually going to are going to define what wounds are. Like they're going to tell you if it's a pressure injury. They're going to tell you if it's wound unstageable, etc. All you need to do is know wound unspecified. The only exception would be if you know it's a surgical incision, which typically they come from the OR and they have the incision already documented, or if it's a puncture site due to some sort of cath or something, or if it's a skin tear. Anything else you don't need to classify. Let them decide what it is and pay for it. So wound unspecified. The second thing is consulting to wound and ostomy nurse within 48 hours of admission. The wound ostomy team is finding that a lot of times they're getting consults 5, 6, 7 days after a wound has been identified. When they got consulted a little bit earlier, we could have already had maybe been on top of it, it would have gotten better. Now certainly patient status change. Sometimes they come in that their skin is great and then they get really sick, or maybe they go to the ICU and come back. So it's not always a one size fits all. But the earlier you consult to wound and ostomy, the better that we can have the documentation trail. Secondly, I don't know if most of you knew, I didn't know, when I first started at Novant, there is a skincare order set that you as a nurse can order as a protocol or as a per standing order. You don't have to have a physician or a wound ostomy nurse order it. And I have that if anybody's interested in looking at it. But basically it allows you, if they have a skin tear, it allows you to put in orders for saline moistened gauze, Vaseline gauze, things like that. It also allows you to put in barrier cream orders for somebody who's incontinent. Incontinent patients are up to 60 times more likely to get some sort of pressure-related injury than patients who are not continent. There's also a correlation between older patients, surprise, and patients who have poor nutrition and are underweight. So you can already go ahead and put those interventions in as a nurse as part of your bundle. And also finally, I would encourage every one of you to attend the Skincare Essentials class. During COVID, they briefly paused it, but now it is back up. It is a 4-hour in-person class. It is led by the Wound and Ostomy team and clinical education. And I learned so much going to that class when I first started at Novant. And I really think that'll help you learn to document wounds, it'll help you learn to assess wounds, how to place your consults, what you should and shouldn't be doing as far as the products we have available. I'll briefly discuss on the evidence, just that early, timely documentation obviously increases our outcomes. It gets wound and ostomy on board quickly. Prevention measures, assessment of risk is important. We use the Braden scale, which is great. It's not always going to catch everybody that's at risk for skin impairment, but if you use the Braden scale, and if they're continent or not, that's a pretty good indicator if they're at risk for skin breakdown. Pressure reducing support services, that is also important. That is going to be the role of our wound and ostomy team. If they need a different kind of bed surface, like an air mattress, and of course education, which is the Skincare Essentials class that I mentioned. So basically all this together comes down to a multimodal approach. I'm not going to just sit here and tell you and then you're going to say, oh, I know what to do and it's great. It's going to take time and effort, support from your managers, support from education, and supporting each other. And I'll say I don't have any CNAs in here, but your CNAs are also great. If a CNA, they're the ones who are more changing the patients, mobilizing the patients, so they're important. They can come to you, say, hey, I noticed this spot on, your patient's bottom. I think you should come look at it. Take that seriously, because they can't document anything with skin, but they can definitely tell you about it. Our outcomes are basically just our interventions and what we're looking for. We want the wounds to be documented appropriately, including the type, the location, and the description. So all you're doing is documenting what it looks like, where it is, does it have any exudate, does it have any odor, and then put in your wound consult. They'll take care of the rest. We'd like 80% of charts to have that compliant. And that's a large goal, because they've been a lot less than that. And also, wound and ostomy nurses are consulted within 48 hours of admission. If a wound is documented as present on admission, a BPA will automatically fire for your consult, so be sure you acknowledge that. There has also been an issue with wounds that are not removed. So when you're going down your admission navigator on your LDA tab, if you notice that an incision is still there, say they had a knee replacement a year ago, well, that's all healed up. You can go ahead and remove that, because sometimes the wound team gets consulted for wounds or incisions or puncture sites that have been healed for over a year, and that takes up their time when they can be seeing other patients. Like 80% of the unit inpatient staff to attend the Skincare Essential class by the end of December of 2021. All you need to do is go into iLearn and sign up, and of course that'll be with support of your managers. And also that the skincare bundle is ordered for patients 80% of the time, whether they're incontinent, whether they have a wound, or if their Braden scale is less than 18. So obviously this is not free. It's a cost benefit to what we implement. It's gonna have to pay for your time to go to take the class. And they have to change some things within Dimensions, which there's currently a best practice advisory council with wound care that we're working on getting some changes in Dimensions to make it easier, because there's a lot of choices that don't apply. And cost to generate the reports, the cost to the wound care team, the cost to managers that may be doing auditing reports. That takes time away from other things that they have to do. But I think the benefits will largely outweigh these costs as described. If we're spending, I don't know how much Novant is costing with possibly wound care. I didn't have numbers, but if it's $11.6 billion to the whole country, even just several $100,000 in savings is worth it. And that's my presentation. Thank you.